Welcome to this lecture on personality disorders from an EMS perspective. In this series, we will cover what personality disorders are and why they matter to us as EMS professionals. We will explore the major types of personality disorders and discuss how patients with these conditions might present during 911 calls or patient transports. The goal is to help you recognize potential personality related behaviors, ensure scene safety, and provide compassionate, effective care. By the end, you should have practical strategies for communication, de escalation, and documentation when encountering patients who may have a personality disorder. Let's get started. Why do EMS professionals need to learn about personality disorders? First, they're more common than you might think. Roughly 9% of adults have some form of personality disorder. This means it's likely we will encounter these individuals during our calls, especially in behavioral or psychiatric emergencies. In fact, patients with certain personality disorders, like borderline personality disorder, are frequent users of emergency services during times of crisis or self harm. Second, these disorders can significantly impact our calls. A patient's personality driven behaviors might make communication and cooperation difficult. For example, they may be mistrustful, agitated, or noncompliant. These behaviors can also create scene safety concerns, such as risk of violence or self harm. Understanding personality disorders helps us handle such situations more effectively and safely. Let's define personality disorders in simple terms. These are long term patterns of behavior, thoughts, and emotional responses that are inflexible and unhealthy. Unlike a short term illness or acute condition, a personality disorder is part of a person's enduring way of interacting with the world. These patterns often cause problems in the person's relationships, work, and daily life. Importantly, people with personality disorders usually don't recognize that their behavior is problematic, which makes these issues hard to change. Clinically, personality disorders are categorized into three clusters based on similar characteristics. Cluster A, or odd or eccentric disorders, these individuals might seem strange or detached. Cluster B, or dramatic or erratic disorders, these involve unstable or unpredictable emotions and behaviors. And cluster C, or anxious or fearful disorders, people in this cluster are dominated by anxiety and fear. We'll go through each cluster and the specific disorders in them. Remember, the goal is not for you to diagnose someone, but to recognize the patterns so you can adjust your approach during patient care. Cluster A includes the odd or eccentric personality disorders. There are three types. Paranoid personality disorder. These patients are highly distrustful and suspicious. They often believe others are out to harm or deceive them, without sufficient reason. In an EMS scenario, a paranoid patient might question your intentions or refuse treatment because they suspect you're not actually there to help. They may appear hostile or guarded. Schizoid personality disorder. Think of schizoid as the classic loner. These individuals are very detached from social relationships and show a limited range of emotions with others. They might seem cold or indifferent. On a call, a schizoid patient could be very quiet, avoid eye contact, and not engage much. They typically won't cause disruption. They just prefer minimal interaction. Schizotypal personality disorder. These patients display odd, eccentric behavior and thought patterns. They often have unusual beliefs or magical thinking, for example, believing in special powers or odd superstitions, and are very socially anxious. In the field, a schizotypal patient might act in a bizarre manner or say things that don't quite make sense to you, almost like mild psychosis, but not as severe as schizophrenia. They may be uneasy with your presence. While cluster A patients are less likely to call 911 themselves, you might encounter them on calls initiated by others, family, bystanders. The key challenge is often communication. For example, gaining the trust of a paranoid patient. Patience and clear, honest communication are important. These patients are usually not violent unless severely provoked, as in paranoid cases, but paranoid individuals could become hostile if they misinterpret your actions, so be mindful of their perspective. Cluster B contains the dramatic, emotional, or erratic personality disorders. These are often the most challenging in emergency settings. The four main types are borderline personality disorder, BPD, hallmarked by extremely unstable moods and relationships. These patients often have an intense fear of abandonment and can be very impulsive. They might go from calm to highly emotional in seconds. Self harm, like cutting or intentional overdoses, and suicidal gestures are common in BPD. In EMS calls, a borderline patient might be the person who one moment begs for help and the next moment pushes you away or yells at you. They can form a quick attachment to a provider, seeing you as a savior, or suddenly perceive you as an enemy if upset, a phenomenon called splitting. Expect rapid mood swings. These patients are high risk for repeat 911 calls due to self injury or suicidal crises. Antisocial personality disorder. This is characterized by a pervasive disregard for the rights of others and social norms. In plain terms, these individuals frequently break rules or laws, may lie or con others, and often lack remorse for their actions. They can be aggressive or violent. In the field, an antisocial personality might be encountered as a perpetrator of violence or someone who is combative with EMS. For example, a patient who got into a bar fight and is still hostile toward you or others could have antisocial traits. Scene safety is a big concern here. Studies have found that patients with antisocial personalities have some of the highest rates of assaultive behavior toward healthcare staff. Always be prepared for potential violence or the need for police assistance with these patients. Histrionic personality disorder. Think dramatic and attention seeking. These patients experience intense emotions, but often in a shallow way, and they have a strong need to be the center of attention. They may dress or behave flamboyantly. In an EMS context, a histrionic patient might exaggerate symptoms or emotional reactions. For instance, being very theatrical about their pain or fainting, perhaps beyond what their medical condition would indicate. They might also be overly friendly or flirtatious with providers. While they are usually cooperative with treatment, the challenge is often managing the drama and distraction. Keep them focused on the care they need without dismissing their feelings. Narcissistic personality disorder. This involves a pattern of grandiosity and entitlement. Patients believe they are superior and crave admiration. They often lack empathy, meaning they don't really understand or care about others' feelings. To EMS, a narcissistic patient might present as the difficult patient with an attitude. For example, a person who demands special treatment, insists on going to a specific hospital because I know the chief of staff, belittles the crew's capabilities, or refuses to follow instructions because they think they know better. They are highly sensitive to perceived criticism or disrespect. Even a small remark can set off an angry reaction or outright refusal of care. Managing these patients requires a calm, professional approach without engaging in power struggles. These are the personality disorders that EMS professionals are most likely to find challenging during calls. They can produce volatile scenes. Borderline and antisocial types, especially, might create unsafe situations through self harm or aggression. Communication can be difficult because these patients may manipulate or test limits, and their reactions can be extreme. Being familiar with these tendencies can help you stay one step ahead. You might recognize, okay, this person's behavior fits a pattern, so I need to stay calm and not take the bait. We'll discuss strategies for that soon. Cluster C personality disorders are dominated by anxiety and fear. These individuals are not usually disruptive. Instead, the challenge is often getting past their anxiety so we can help them. The three types are avoidant personality disorder. These patients have deep feelings of inadequacy and are extremely sensitive to any form of criticism or rejection. They desire relationships but avoid social interaction out of fear of being judged or rejected. In practice, an avoidant patient might hesitate to call 911 even when they need help, or if someone else calls for them, they might downplay their symptoms or be reluctant to talk to you. You might notice they seem intensely anxious, withdrawn, or ashamed. They may repeatedly say, I'm sorry to bother you, or worry about being a burden. For EMS, the key is gentle encouragement. They need reassurance that it's okay to accept help. Be patient if they have trouble speaking up. Dependent personality disorder. This is characterized by an excessive need to be taken care of. Dependent patients are very clingy and have difficulty making decisions on their own. They constantly seek reassurance. In an EMS scenario, a dependent personality might be the frequent flyer, who calls often for relatively minor complaints because they feel they cannot cope alone. For example, an individual who calls 911 weekly for mild symptoms mainly because they want someone to attend to them or tell them what to do. On scene, they may latch onto a provider and not want you to leave. They might ask you repeatedly, You won't leave me, right? Or have trouble if you suggest they might not need transport. These patients are usually polite and willing to follow care instructions, but their over reliance can be challenging, especially when EMS resources are limited. It's important to treat them with respect and provide guidance, but also to encourage appropriate use of EMS and connect them with other supports if possible. Obsessive compulsive personality disorder, OCPD. Note, this is not the same as OCD anxiety disorder, though they share some features. OCPD patients are perfectionists who need order and control in every aspect of life. They are inflexible about rules and procedures. Everything must be done their way. Unlike people with OCD, those with OCPD usually don't see their behavior as a problem. They think everyone else is too lax. In the field, an OCPD personality might manifest as a patient who is very particular and controlling about their care. For instance, they might insist you handle them or their belongings in a very specific manner, or they'll question every step you take. Are you sure the ambulance is clean? Can we take my preferred route to the hospital? They might become anxious or upset if anything seems out of order. While generally not aggressive, they can slow down your care with their need for control. The best approach is to explain what you're doing clearly and, when safe, give them small choices to satisfy their need for control, like letting them hold their own medication list or involving them in decisions. Which coat would you like to bring with you? Cluster C patients are usually non threatening, but their anxiety can still pose challenges. Avoidant and dependent personalities may have issues with decision making, like refusing transport out of fear or conversely calling too often. OCPD individuals can test your patience with their rigidity. The common thread is anxiety, so a calm, reassuring approach works well. Give these patients time to process and don't dismiss their fears. Helping them feel a bit in control, like providing information and choices, can improve cooperation. It's important to spot red flags that a situation is escalating or that you're dealing with a personality driven behavior that could become unsafe. Here are some warning signs. Escalating agitation. This can apply to any patient, but in personality disorder cases, you might see a quick ramp up. If a patient begins yelling, cursing, or making aggressive gestures like pacing around, clenching their fists, or pointing fingers aggressively, take note. In antisocial or narcissistic personalities, agitation can lead to violence. In borderline personalities, agitation might lead to self harm or attempts to flee. A loud, increasingly hostile tone is a big red flag that you need to implement de escalation techniques. We'll cover those next, and possibly call for extra help. Sudden mood swings. All patients can be stressed, but extreme rapid mood swings are a hallmark of certain personality disorders, notably borderline PD. Be alert if a patient goes from cooperative to furious or distraught very suddenly without a clear medical reason, not due to pain spikes or anything you can identify. For instance, a BPD patient might be joking with you 1 minute and then sobbing or screaming the next because of a perceived slight. Such volatility is a red flag that the situation could get out of control if not handled carefully. It's also a sign that you should adjust your approach, often by slowing down, ensuring the patient feels heard, and being very mindful of your words. Paranoid statements or behavior. If a patient starts saying things like, "I know you're lying to me," "You're with the police, aren't you?" or "You're trying to poison me with that IV," these are clear indicators of paranoid thinking. It might be due to paranoid PD or could even be acute psychosis, but regardless, it's a red flag. Paranoid patients can become fearful and potentially aggressive if they believe you're a threat. Also, watch for physically defensive behavior, like withdrawing or watching your every move suspiciously. Recognize these signs and switch to a very transparent and reassuring communication style. Explain everything you are doing in simple terms and ask permission when possible to reduce their fear. History of frequent crises or violence. If you have prior knowledge from dispatch info, med alerts, or bystander or family comments that this person calls all the time or last time he fought the medics, treat that as a red flag. Repeat self harm calls, common with some BPD patients, mean this patient is likely emotionally volatile and potentially suicidal, so be prepared for intense emotions or manipulative behavior. A history of violence speaks for itself. You should quietly ensure law enforcement is present or nearby and have a game plan for safety. It helps to quickly huddle with your team when you get such info. For example, "All right, this patient has a history of spitting and punching, so let's keep sharp and I'll do the talking." In summary, when you notice these red flags, don't ignore them. They are cues to start de escalation tactics, adjust your communication, and possibly involve additional resources. Staying alert to these early warning signs can prevent a bad situation from getting worse. We will wrap up part 1 here. Join me in the next lecture to discuss how best to communicate with these patients when you encounter them in the field. See you then.